Good afternoon and welcome to Facebook Live with Holy Cross Health. My name is Brenton Andrasic, Manager of Physician Alignment and Business Development at Holy Cross Health. Before we begin, I'd like to call your attention to a few ground rules that you'll see in the comments section. We encourage you to participate, but please keep any questions and comments general. We won't be discussing anyone's specific health situation in this public forum. If we can't get to every question today, we'll provide additional feedback through Holy Cross Health's blog, or we can connect with you through one of our program channels by phone or by website. For those of you joining us today on Facebook, we thank you for being here and for taking an active role in your health, and we at Holy Cross are happy to be your partner in your health journey. Today we're here with Dr. Albert Starin, Medical Director of Gynecologic Oncology for Holy Cross Health. So Dr. Starin, thank you for joining us today to discuss this important topic.
Thank you.
Let's start broadly. What are some of the symptoms or issues that might lead a woman to seek care in your office?
Well, typically we see patients who have symptoms that bring them to the gynecologist, such as abnormal bleeding, abdominal distension, bloating, pain. Those are things that might take them to the doctor. And then after an evaluation or workup, they generally will get sent to us if there's an abnormal finding. Either a biopsy was abnormal, a mass on an ultrasound was abnormal, a Pap Smear screening test was abnormal. So those are some of the things that would take a woman to a gynecologic oncologist's office.
So you mentioned that a positive Pap Smear could lead a woman to seek out your care. Can you tell us a little more about that test? How does it work? Who should get it? When should they get it? How do you interpret it? All of that good stuff.
The Pap Smear is really a great screening test. It's probably the world's greatest screening test. It's relatively cheap. It's easily doable. It's relatively acceptable to the patient to have done. And it's relatively accurate. And it's really been a huge success story. The incidence of cervical cancer, which was a tremendous problem in the United States years ago, and still is a tremendous problem across the world, has really gone way down in incidence because of the success of the Pap Smear. Essentially, what it does is it scrapes the cervix, and what's known as the squamocolumnar junction, that portion of the cervix where abnormalities do arise, and it lets us know, is there some problem that needs further evaluation? And in particular, nowadays, we frequently test for human papillomavirus, the etiologic agent that causes most of the abnormalities that arise on the cervix.
So I want to make sure that we get to viewer questions throughout this event. So people had the opportunity to submit questions when they pre-registered. So we'll be periodically mixing those in as we go along. And I think that several of the questions that were asked would be relevant here. One person asked, how often should women over 50 get a Pap Smear?
Well, that's really a pretty broad question, depending on what the situation or the issue is. The guidelines for people who have no particular symptoms are that between the ages of 30 and 65, that they have a Pap Smear every 3 years or a Pap Smear and HPV test, which is called co-testing, up to every 5 years, up to the age of 65. So until you're 65, you still need to have regular Pap Smears if everything has been normal. After the age of 65, if there have been no abnormalities, you don't need any more Pap Smear screening. And of course, if there have been any surgical procedures such as hysterectomy for benign disease, and the cervix also has been removed, no matter what age that procedure is done, you no longer need Pap Smear screening after that.
Right, that makes sense. So if a woman comes to you with a positive Pap Smear result, what would be the next steps in diagnosing the root cause of that positive test?
The thing to remember is the Pap Smear is just a screening test. And so if the screening test is abnormal, then further evaluation and workup is required. Just like the mammogram is a screening test, and if there's an abnormality, then further evaluation and workup is required. For abnormal Pap Smears, we do something called colposcopy. Colposcopy is where essentially we put a solution on the cervix. It's a vinegar solution, acetic acid, that brings out the abnormalities so that we can see them more clearly. In fact, we call it acetyl white epithelium because the vinegar solution brings the abnormalities out and makes it easier and brighter and easier for us to see We then take the colposcope, which is essentially a great big microscope, and examine the cervix or the vagina or the vulva or any of the areas that require further evaluation, and take a close-up look at what the abnormality might be, and if appropriate, we would take a biopsy. And then depending on what the biopsy demonstrated, that would then determine if any other treatment would be required. So the first next step in terms of workup of an abnormal Pap smear typically would be colposcopy. Again, it's important to talk with your physicians because some abnormal Pap smears just require a repeat test without any type of invasive evaluation. But colposcopy is really the way to work up an abnormal Pap smear.
Mm-hmm. So when we started, you mentioned some other symptoms that can lead women to seek care. What are some of the symptoms that women should never ignore?
Well, some of the things that we see pretty regularly are things like menopausal bleeding. Once a woman becomes menopausal, which on average is about age 52, some of course before, some after, there really should be no more spotting or bleeding. So any menopausal spotting or bleeding at all, abnormal bleeding, irregular findings should take you to see your gynecologist. And often a pelvic ultrasound might be ordered, and certainly an endometrial biopsy might be considered. The biggest difficulty that we have is screening for ovarian cancer, which unfortunately has no good screening test. They looked at pelvic ultrasounds, they looked at blood tests with CA-125, and there really hasn't been a good way that's been developed to pick up this pretty aggressive disease early. And so we really count on the patient bringing to our attention any symptoms that would be out of the ordinary, in particular things like abdominal distension, bloating, pain, bleeding, of course. Now, many of those symptoms are pretty general, could be caused by a million different other medical conditions. And so certainly if you have abdominal distension or bloating, it doesn't mean you have ovarian cancer. But certainly those types of symptoms should be brought to the attention of your physician.
So we've mentioned a few different types of cancer at this point. What are all of the different types of cancer that you treat in your practice?
Well, a gynecologic oncologist specializes in the treatment of abnormalities or cancer of the female reproductive system. So that would include the ovary, the fallopian tubes, the uterus, the cervix, the vagina, the vulva. So any of those areas, any abnormalities of those areas comes under the purview of a gynecologic oncologist.
And while we're talking about gynecologic oncology, what are some of the risk factors for gynecologic cancer that women should be aware of?
Well, it depends again on the cancer. I'll just take a couple examples. Cervical cancer, which we talked about initially with the Pap smear, the etiologic agent for that is the human papillomavirus, which is a sexually transmitted disease. And so people who have exposure to HPV will have an increased risk of developing abnormalities of the cervix, vagina, and vulva, and even cancer. Some of the other risk factors include things like obesity, which is a predisposing factor for endometrial cancer because of the relative excess of circulating estrogen, hypertension, diabetes. All those would be risk factors for uterine cancer. And for ovarian cancer, some of the risk factors might include nulliparity, meaning never having been pregnant or given birth, continuous ovulation, so that means early menarche, starting your periods early, and late menopause, going into menopause late. So that continuous irritation of the ovarian stroma, the outside of the ovary, we think in large part predisposes or increases the risk for developing ovarian cancer. So depending on the cancer, there can be a variety of different predisposing factors and symptoms that would give us a clue that there's a problem going on.
Yeah, that's a lot of great information there. And we had a few questions come in both before the event, and we've already had one here during the event revolving around risk factors. So I'd like to cover those now. One person asked, my mother was diagnosed with uterine cancer at age 89. Is there a specific screening for uterine cancer?
There really is no specific screening test for uterine cancer unless there are symptoms, and then the test would be a diagnostic test such as an endometrial biopsy. There are, however, some familial groups, some genetic predispositions that do increase the risk of uterine cancer. For example, Lynch syndrome, which generally people think of as associated with colon cancer, also has a very strong propensity to uterine cancer as well. So although there's no screening test, someone whose family history might suggest uterine or colon cancer should have a blood test screening for a genetic predisposition. But if your mother was 89 years old at the time of diagnosis, it may be that it was just a de novo issue, something that just developed out of the blue without a predisposing factor.
So it's interesting that you mentioned colon cancer because we just got a question in that relates to that. So one person asked, are uterine, ovarian, and colon/intestinal cancers related? And if so, can a woman have an increased risk of cancer if their mother or grandmother had any of those cancers?
Well, absolutely. In part, adenocarcinomas, cancers of many organs, breast, ovary, uterus, colon, do kind of travel in packs. So having one does increase the risk of others. And in particular, to address your question, for colon cancer, Lynch syndrome, which has a 40 to 60% chance of developing colon cancer throughout a woman's lifetime, does also have a 40 to 60% chance of developing uterine cancer throughout your lifetime, and a 10% risk of ovarian cancer as well. And so the two most important factors for the development of cancer of the gynecologic organs include, number one, age, and number two, familial history. So if there's a significant history of cancer in your family, it is very important, vitally important, that you bring that to the attention of your physician, and you might require genetic screening, counseling, and even blood tests to determine if you are at risk.
So we have one more question that I think relates to this, and someone asked if you've had an ovarian cyst removed in the past, does that make you more susceptible to having ovarian cancer later in your life?
It does not. Having ovarian cysts by itself is not a pre-malignant lesion. It is not considered something that would increase your risk of developing ovarian cancer. Cysts of the ovaries are very, very common. The ovaries, their job is to make cysts that come and go and come and go. And so by virtue of having a cyst alone does not increase your risk of having ovarian cancer. They're not considered pre-malignant.
So we've covered a lot of ground there, lots of great information. I think that we were able to answer some people's questions. I'd like to move on from our discussion of screening and diagnosing to a discussion about treatment. If we have a diagnosis, what can we now do about it? So, Dr. Staron, you're a surgeon, so let's start with surgery. Can you tell us about the surgical interventions for gynecologic cancer that are available here at Holy Cross?
Certainly. Well, the majority of gynecologic cancers do include, as part of the treatment modality, some type or element of surgery, whether it's a hysterectomy or removal of the ovary or D&C. And Holy Cross has been a leader in gynecologic oncology surgeries in particular, and gynecologic surgeries in general. Really, they do the most gynecologic oncology procedures in Montgomery County or PG, and the most in the local region. And so Holy Cross is well suited, well adapted to doing these kind of procedures. And now really the trend, just like in many other subspecialties, the trend in gynecologic oncology is to treat these abnormalities through a minimally invasive approach. And so many aspects of care, treatment of uterine cancer, treatment of ovarian masses, are done through a minimally invasive approach, and in large part they're done robotically. So although we call it a robot, it's not really a robot. It's more like computer-assisted laparoscopy, but the dissection is more meticulous and precise. Tissue trauma is less. Recovery is much faster. And Holy Cross is lucky enough to have 3 of the most advanced robots on the market for gynecologic surgery. And so we're very delighted to have access to that advanced technology.
Absolutely. So, what are some of the types of procedures that can be performed using those robotic or minimally invasive techniques?
Well, uterine cancer for now, at the moment, the standard of care is really to remove the uterus, cervix, tubes, and ovaries through a minimally invasive procedure, generally robotic. That would include lymph node dissection, lymph node sampling, removal of any tumor in the abdomen, removal of the omentum, sometimes even removal of portions of the intestine. All that can be done through minimally invasive approaches nowadays. Same with ovarian masses. Those are typically done laparoscopically or robotically. Cervical cancer, now we do those mostly as open procedures because the studies do show that those patients do better with open operations. But for uterine cancer, ovarian cancer, and other gynecologic organs, the outcome between laparoscopic and open procedures is equivalent in terms of cancer outcome. And the recovery is so much faster when done through a minimally invasive approach. And so, where possible, we try to offer that to the patient.
So we're throwing around a few terms here. I just want to make sure that we're clear for everyone who's watching on Facebook. Could you just talk a little bit more about the difference between open versus laparoscopic versus robotic, so we can be very clear about what each of those terms actually means?
Sure. Open is when you make a big incision and go in and do the surgery through a big incision. Sometimes that's still indicated. We do that for what's known as big debulking operations for people who have, unfortunately, disease everywhere that can't be removed laparoscopically, require a big operation. Laparoscopy, or minimally invasive surgery, is done through what we call keyhole or belly button type openings, incisions in the abdomen, which are really small. We operate while looking at a video screen, kind of like looking at a television set, and do the surgery that way so that the recovery is much faster. And robotics, although it's not really a robot, it's more computerized laparoscopy. We still do through small incisions, but visualization is amazing because it's 3D, so we get perspective, we get depth, as well as the 2D that you see on a television. The instrumentation is very precise and meticulous. The hands are built and designed to mimic human hands and human articulation. So you can do all the movements that you would do normally in an open operation through this robotic procedure. It's really an incredible feat of engineering. It's amazing stuff.
Yeah, it really is incredible technology that we have available to us here. How do you determine that surgery or other types of procedures are necessary for a patient? You mentioned that that is often indicated, but how do you determine that that is the correct course of action?
Well, we're very pressed or very focused on multimodality therapy and having all the different subspecialties come together to work out the best treatment option, treatment plan for a patient who might have cancer. So, for example, if someone is diagnosed with a particular type of uterine cancer, we would present that patient to our tumor board where many subspecialties are sitting around the table looking at the pathology slides, looking at the radiology. We would have radiation oncologists, medical oncologists, surgeons of all types, and gynecologic oncologists as well, and come up with a consensus opinion, a consensus plan on how best to treat that patient. That often includes surgery. Sometimes it doesn't. Sometimes it's just chemotherapy or just radiation. But in many instances of gynecologic cancer, it's usually multimodality treatment, meaning we include all those subspecialties together in designing a treatment plan for the patient.
And I think that's an important point for everyone to remember that you are a surgeon, and of course we're talking about surgery, but the program at Holy Cross is certainly not limited to surgical intervention. You mentioned chemotherapy. I think this would be a good point to ask if there are any clinical trials available for gynecologic cancers at Holy Cross.
That's really a great question, because I very much encourage people, when able, to go on to clinical trials, because after all, that's how we're going to advance our care and advance our treatment. Number one, Holy Cross is lucky in that we have subspecialists in all different types of fields, expertise all across the board. And we have a whole series of clinical trials specific to gynecologic oncology. So for patients who have a particular tumor, who are then presented at the tumor board, as part of the tumor board, we look to see, are there trials that are available for this particular patient? And if so, we try to make every effort to present that as an option to our patient, and where appropriate, to encourage them to go on to a clinical trial.
So I think it would be helpful for people listening. Let's say I'm a patient and come with a diagnosis, and we determine that surgery is the correct course for me. What could I expect as a patient in the process leading up to surgery?
Well, the process is really very involved in the sense that we do a lot to try to make sure that the surgery goes as smoothly and uneventfully as possible, as well as the recovery and then the transition to follow-up care. So as part of the process, you come in for your initial consultation and evaluation. We present the tumor board presentation and make a plan. You then come back to discuss the enhanced recovery protocol that we have for our patients, where we talk about what the surgery would entail, what the anesthesia would entail, what the hospital course would entail, what recovery would look like, and we talk about things like pain management and activity level and sexual function, all those things that are important after gynecologic surgery. We try to make sure that we address them as best as possible before surgery, so that we have a plan in place once surgery is complete.
And we are in the midst of a pandemic, and I'm sure that a lot of patients are concerned about how we handle COVID testing for patients. And so can you just talk a little bit about how we've approached pandemic safety?
Absolutely. Well, for one, the operating room is kind of away from the other patient floors, the COVID floors, so the risk of exposure is relatively small. Every patient who comes into the operating room is tested. Staff also is vaccinated and tested, but every patient who comes in is tested. So none of our patients have ever been exposed or infected with the coronavirus through surgery. So they're very careful and meticulous about making sure that everybody is appropriately distanced where appropriate, tested when needed, and then vaccinated nowadays as much as possible.
And you mentioned recovery earlier. I know that's a lot of patients' key area of interest. Clearly, this differs depending upon the procedure that's performed, but in general, could you just talk a little bit about what the recovery process typically looks like?
Sure. A robotic procedure might be an outpatient procedure. For example, a robotic hysterectomy, removal of the ovaries, lymph node dissection, nowadays typically is outpatient surgery, so you go home the same day. Recovery is about 2 to 3 weeks, not 2 to 3 weeks in bed, but 2 to 3 weeks before you feel like your old self again. There are very few restrictions, but there would be no driving for about a week, no heavy lifting for about a week, nothing more than about 5 pounds or a gallon of milk. You could be a passenger in a car, you could take stairs, walk around the house, shower, do all that kind of stuff. For an open operation, or an incision in the abdomen, typically that would be a hospital stay, anywhere from 2 to 5 days, depending on the operation. And the recovery from that is much longer. It's generally about 4 to 6 weeks with a lot of the same restrictions. And so that's really the advantage to laparoscopy and robotics. We get people back to their normal daily activities, back to work, back to their families, much faster than an open operation. But those would be what the recovery period would look like.
So we've covered prevention and screening, and we've covered diagnosis, and we've talked quite a bit about therapies and treatment. I'd like to zoom out for a minute and talk about the program as a whole at Holy Cross. You know, one thing I'll let you say, Dr. Starin. What do you think is something that makes the gynecologic oncology program at Holy Cross unique? And I think that part of that might involve the team of providers and the other team members that can be involved in patient care here.
Absolutely. I think that's really the primary differentiating factor, that we have a phenomenal team, starting from nurse navigators who are able to walk the patients through the entire procedure, surgery, follow-up. We have the tumor boards where people's different tumors, cancers, or situations are presented so that we can develop a consensus plan on how best to treat that patient. We have access to clinical trials. We have medical oncologists who specialize in gynecologic or women's cancers. We have radiation oncologists who also do the same thing. Here at Holy Cross Radiation Oncology, we have access to what's known as brachytherapy, which is the type of radiation which is in large part specific to gynecology that other centers do not have access to. And so we really have the whole spectrum of availability of expertise that can take the patient anywhere from diagnosis to treatment to recovery to improvement of function throughout their entire course. And we have people who will help walk them through that entire process. I think the fact that we're so patient focused really is what sets our program apart from others.
Absolutely. And, we've talked a lot about gynecologic oncology today, but that's not the entire scope of your work. What are some of the other conditions that you treat and other procedures that you perform?
Well, Holy Cross is lucky in that we have we are the only hospital in the area that has a center certified for excellence in minimally invasive gynecologic surgery. So we have experts in gynecologic surgery of all types. And so we treat patients who have fibroids, who have endometriosis, who have irregular bleeding or infertility, things like that. And we are lucky that we have this certification, this center of excellence, that nowhere else in the DMV has that certification. So that really puts our expertise at a different level, I think, than would be found at other locations in this area.
And related to that, we did have a question that came in from Facebook while we were chatting. Someone asked, what are some current possible treatments for urinary incontinence? This person mentioned in particular Botox, mesh surgery, and pessary, and how does one choose between those treatments?
That is a very good question, and I would have to say there's a whole field of urogynecology that's been developed around that specific topic, and we have several fantastic urogynecologists here at Holy Cross. And so without trying to duck the question, my answer to that would be I would defer that to a urogynecologist, and I would encourage you, if you have incontinence, to make an appointment with one of our terrific urogynecologists to talk about those issues.
Absolutely, and it does point to the fact that here at Holy Cross we do have an entire team dedicated to women's health, not just to gynecologic oncology, but many different aspects of women's care.
Absolutely.
So, Dr. Starin, we're about out of time. So thank you everyone for tuning in today. If we didn't get to your question, we're planning to provide additional info through Holy Cross Health's blog, or we can connect with you one-on-one through our gynecologic services channels via phone or our website. You can connect with us to learn more about gynecologic surgery and cancer care at Holy Cross Health. For the gynecologic surgery program, you can call 301-754-7278 or visit holycrosshealth.org/GYN. And for our cancer care services, you could call 1-855-HCH-HOPE or visit holycrosshealth.org/cancer. Thank you for joining us today on Facebook Live with Holy Cross Health. We hope to see you again soon.
Thank you, Brendan.